brown rice?
Eh?
Which one is brown rice again?
There's a brown rice, but it doesn't taste good. I've tried
Is
this
it ofada rice?
it's not like ofada rice, so I've tried it, Dr. D. It's in Tesco, it's in all the shops. But it doesn't sweet
Eh.
like rice. It go just the sweet like another thing. So me, what I do is that I just eat small quantity of rice. That's what I do.
Okay.
I don't, because it doesn't work for me at all. So after rice, the next one is baked potatoes, then white bread. Thank God, I no longer eat white bread. I win successfully from that one. Only intermittently I crave for white bread, then I'll go to charity store and buy that Nigerian one I crave for. Then I'll eat it
Okay.
and I'll stop. Yeah. Then medium GI, so medium glycemic index. You have the COCOS 65. Is it? Or did he say which one is COCOS again? Hey, these people.
Cough, cough. What's
Is it
cough? I've never
couscous?
heard
Let
of
me
that
check
before.
it. I've not heard it before too. Couscous.
It's actually a salad. Oh no, say
Ah,
it's a more
okay.
recent.
This
It's
thing.
like Gary.
Yeah. Roasted vegetable flavor couscous. Hey, Chineke. It's in Tesco,
Now,
sef. It's in Tesco. Okay, so couscous has 65. Boiled new potato. So if boiling potato is better and safer for you, okay? Boiled new potato. Digestive biscuit. Digestive biscuit. So digestive biscuit is medium. Then brown rice. Oh, so brown rice is in medium. Let me be eating my high one, but eat small quantity because so but it's 58 against 87. So it's quite, yeah. Then low, you have fruit and vegetables and peanuts. So fruit and vegetables and peanuts are this thing. Then the glycemic index is, so remember fruit and the vegetable, remember peanuts. For medium, remember couscous, boiled potato instead of the baked one, digestive biscuit and brown rice. Then for the high one, remember white rice, baked potatoes and white bread. The glycemic index is shown in bracket. Glucose by definition would have a glycemic index of 100. Oh. So summary of national guidance for lipid management for primary and secondary prevention of CVD. Okay, oh guys, look at this diagram. Look at this diagram. Let's see who can surmount it. So primary prevention consider starting therapy for adults that do not have established CVD but fall into the categories below. Use key risk assessment tool where appropriate. So consider starting therapy for adults that do not have established CVD, okay, but they fall into the categories below. Now, for primary prevention, okay, what are we doing? I'm trying to understand the diagram. Dr. D, do you understand the diagram?
let me see. For which one? Is it all the diagram?
I'm still at that first one. So they're talking about, okay, yes, I've understood it. So what they're saying is for people to commence on primary prevention, right? Where are the
Yeah.
people you can commence on primary prevention
You
for
have to
cardio?
be age less than
Yes,
84
age less than
years.
or equals to 84, and their
Yeah.
key risk is greater than or equals to 10%
Yeah.
over the next 10 years. You have to commence them on starting. Then type 2 diabetes and key risk greater than or equals to 10% over the next 10 years. So if they have type 2 diabetes and their key risk is more than 10%, obviously we know about the key risk being greater than or equals to 10%, we want to consider starting. But other ones you have to consider is things like if the age is less than or equals to 84, type 2 diabetes and key risk, type 1 diabetes if they have one or more of the following.
Those are the exceptions where you don't need Curix before you start them on
Yes,
starting.
exactly. So here now we
So if
don't need
you've got
key
type
risk.
1 DM,
Exactly.
CKD, stage 3, and
Yes.
age more than 85
Age
years.
more than, and
Yeah.
that, they used to ask it. As I think it was in past medicine or one of that they will ask it. So
Yeah,
which
it's
of
in
this one
past
will you not
medicine.
use key risk?
I mean, who
So
get this material? Is it for the group?
no, I paid though. And
Ah,
you see why? Let me tell you why
are you
people are not.
serious?
Do you know why people are not sharing it? You don't share because if you pay, they will give you access. It's not like you can have it to now share. As I am now, there is no. I can't be the only good cap Samaritan I can be is as we are reading it together.
Are
That's
you
all.
serious?
Yeah,
How
I
much
can't
did you
share.
not pay?
I everything 400, so I
Ah,
can read all of them.
well,
My dear, anything to pass AKT.
Oma just the
The
doctor,
guy
the
they
mighty
make
Oma
money.
just they make money.
Now
Ah,
so
ah,
yeah, so age less than or equals to 84 and Q is available because everybody wey pass go tell you man note, only if others will say pass
No,
medicine.
but
So
the note is actually rich,
yeah,
actually.
the note is
These things
rich.
are in past medicine, but he added a lot of things.
Exactly, but they are bulky. They are past medicine, but they are made in a bulky way that without this guide and dragging you to things that is important, you will neglect it. That's the thing. So anything at all, I beg, because the mental stress of the exam is
Yeah.
much. So anything to just end it. So primary prevention, consider starting therapy for adults that do not have established CVD but fall into the categories below. We've said it. So type 1 diabetes, if they have one or more of the following, if they over 40 years, had diabetes for more than 10 years, have established nephropathy, and have other CVD risk factors. Then CKD, EGFR of less than 60.
The call will soon end though in 2 minutes time. Oh.
Eh?
The call will soon end in 2
Why is the
minutes.
call ending? Is it because I joined with laptop? This call has started again ending. Okay. I will create let me create another link. Or can somebody else create another link and admit us? Dr. D, can you create another link? Maybe link
Oh yeah,
that.
now.
Please
Yeah, yeah.
create, yeah, so that once you end, we'll join. Put another day we end, we join with your link. Thank you. All right. Where was I? Okay, so CKD with EGFR of less than 60, male, and or albuminuria, then age greater than or equals to 85 years. If appropriate, consider comorbidities, frailty, and life expectancy. So, like the rapport say, the age is greater than or equals to 85 years, CKD 3 and above. Um, the diabetes, type 1 diabetes, they have one or more of the following comorbidities, like over 40 years, diabetes more than 10 years, have established CVD, established nephropathy, have other CVD risk factor. You can start them. Then identify and address all modifiable risk factor like smoking, diet, obesity, alcohol intake, and physical activity, blood pressure, and HbA1c. But unfortunately, when you tell patients that the smoking is bad for them, some of them will just tell you to leave them, that it calms them of stress. But we'll address them though. Then consider additional risk factor if present, together with Q risk score, treated for HIV, severe mental illness. So other additional risk factor that we need to consider is ended. Okay. So guys, if you're with us here, welcome everyone. Hi Melson, hi Rella, hi Suje. So Monkey, Baby Ray, you're all welcome. What we are saying, what you should take off from the study tonight is smoking, lifestyle. Lifestyle modification can help prevent a lot of diseases for you, okay? Try to modify your lifestyle. If you're smoking, could you stop smoking? Okay, reduce alcohol intake to recommended unit of 14. All right, those are the things that are good for your health, guys. Okay, yeah, so those are the things that are good for you, my lovelies. Okay. uh Dolapo, where is the, I can't see the link. Okay. All right, let me share the screen. They go boom boom boom. Oh my connect, I just want make you connect. Okay, so they said you should address all other lifestyle, okay, including smoking, alcohol, physical activity, blood pressure, and HbA1c. Then aside that, consider additional risk factor if present, together with QV score, like treated for HIV, severe mental illness, taking medicines that cause dyslipidemia, systemic inflammatory disorder like SLE, impaired fasting glycemia, recent change in risk factors. Are we all here? Are we all back, Dr. D? Are more people back? We can
I've
continue.
admitted those that were knocking the
That
door
we're
at
knocking.
first.
Okay, all right, let's continue. So primary prevention, if lifestyle modification is ineffective or inappropriate, offer starting treatment. So if lifestyle modification is ineffective or inappropriate, offer starting treatment. It will start in 20 milligram daily. So measure the full lipid profile again after 3 months. That's usually non-fasting, High intensity statin treatment should achieve reduction of HDL by more than 40%, and that is usually the target, more than 40% reduction from baseline. If not achieved after 3 months, discuss treatment adherence, timing of the dose, diet and lifestyle. If at higher risk based on comorbidities, risk score or clinical judgment, see page 2. Consider increasing the dose every 2 to 3 months up to a maximum dose of atorvastatin 80 mg. For how to increase in people with CKD, seek further advice. Seek further knowledge. Now I think we'll see it below. If patient is on high intensity statin and have side effects, offer a lower dose or alternative statin. So if the patient is on high intensity statin, they have side effects, offer a lower dose. If maximum tolerated dose of statin does not achieve the reduction of more than 40% baseline after 3 months, consider adding ezetimibe 10 mg daily. So if you didn't achieve it, add ezetimibe 10 mg daily. Okay. If statin treatment is contraindicated or not tolerated, see AAC statin intolerant algorithm for advice regarding adverse effects. Ezetimibe 10 mg monotherapy may be considered. Assess response. So if the statin treatment is contraindicated or is not tolerated, okay, you can do ezetimibe 10 mg monotherapy. You can consider it and then assess response after 3 months. Ezetimibe 10 mg slash bempedoic acid 180 mg combination may be considered when ezetimibe alone does not control the LDL well enough. What is this bempedoic acid? Can we check it? Bempedoic acid, what is it? So if ezetimibe 10 mg within 3 months does not achieve target, we can add bempedoic acid to it 180 mg. If non-HDL reduction remain less than 40% of baseline despite maximal tolerated lipid lowering therapy, including people with intolerances and contraindication, consider referral to specialist lipid management, okay, according to local guidelines. So what it means that when you have done statins, it didn't work, you add on ezetimibe or give only ezetimibe if they can't tolerate it, or I'll even give ezetimibe in combination with what's the name of that one, bempedoic acid, and it didn't work, you should refer to specialists. So my question now is, which specialists are we referring to? Dr. D. Which
Maybe lipid endocrinologist.
Is it
Lipid clinic, but is it not going to be endocrinologist?
Okay, endocrinologist. Okay, because I know we are doing metabolic medicine, so I want to know, because I don't think I've ever referred anyone.
I've referred to best lipid clinic.
Lipid
It's on
clinic.
the just tax secretary. I referred somebody with familial hyperlipidemia.
Hyperlipidemia. Okay. Now severe.
Yeah, I did something similar, so it was the secretary.
Secretary just sent to say okay.
They
To say
referred to
lipid
clinic. They'll sort that one out.
All right. Now severe hyperlipidemia. If total cholesterol is more than 7.5 and or LDLC more than 4.9 and or non-HDLC greater than 5.9, a personal and or family history of confirmed CHD less than 60 years and with no secondary causes, suspect familial hypercholesterolemia, possible heterozygous, do not use Q risk assessment. So guys, this is very important. If total cholesterol is more than 7.5 and or the LDL is more than 4.9, so 7.5 4.9, 7.5 4.9. If the total cholesterol is more than 7.5, LDL-C is more than 4.9, and or HDL is more than 5.9. So if you're using HDL, it's 5.9. If you're using LDL, it's 4.9. A personal and or family history of confirmed CHD less than 60 years and with no secondary causes, suspect familial hypercholesterolemia, possible heterozygous FH, do not use Q risk assessment too. Diagnosis and referral. Take fasting blood for repeat lipid profile to measure LDL-C. So take fasting blood for repeat lipid profile to measure the LDL-C. Use the Simon Broom or Dutch Lipid Clinic Network criteria to make a clinical diagnosis of familial. So Simon Broom, does anyone know what that Simon Broom is all about? Simon Broom or Dutch?
I don't know.
Should I Google it? Because my dear, what I've learned is don't leave anything untouched. They will go there now, they will leave this one that they wrote here and start asking about Simon Bruce or Dosh, what is all about. Okay, so let me see what that Simon Bruce is here. So Simon Bruce criteria. Can you spell the Bruce for me? Are you still seeing the screen?
It's Broome.
Broome, Simon Broome. Okay, criteria. All right.
Brome.
Thank you. So Simon Broome criteria from MD Cow here will use age in years, total cholesterol, and LDL, as well as the presence of tendons and tumors, DNA-based evidence of functional LDL, PCSK9, and APOP mutation, family history of premature CVD, and family history of extremely high cholesterol. That's what the Simon Broome we used. So it will use age, total cholesterol, LDL, tendons and tumors, DNA-based evidence of functional LDL, and family history of premature CVD, as well as family history of extremely high cholesterol. Those are the things that Simon Broome will use. All right. So let's go back to where we are. So we use our Dosh Lipid Clinic Network criteria to make a clinical diagnosis of FH. Refer to lipid clinic for further assessment. So lipid clinic, if clinical diagnosis of FH is suspected, or TC is more than 9, and or LDC is more than 6.5. So if TC, total cholesterol, is more than, refer to lipid clinic.
I don't think this thing is correct or unique.
Which one?
This TC of 9. It's usually 7.5.
You know, we've read the one of 7.5 now. Look at it. We've read.
They said we are doing familial hypercholesterolemia. Is it not FH, or what's the name of the FH?
So let's complete reading this, because the first thing we read here is we've read that total cholesterol of more than 7.5 we should consider familial hypercholesterolemia. So it's already said it, isn't it? Look at the point here. Do you want to check NICE? Check the word that NICE said, because what is here is that
no. My sorry to drag you. My argument is this: what this diagnosis and referral? What's it all about? What are we diagnosing?
So I think.
So okay. What he's saying for the other one that is 7.5,
you suspect. Exactly.
And you prepare for further
evaluation. But once you don't reach that level, you diagnose it.
It's like you have it's more diagnostic because it's higher. So you have to start treatment
immediately.
And then they're not experiencing
so I just opened past medicine. Past medicine say that NICE suggests that you should suspect. So it's exactly NICE. That in the road there is from NICE. NICE said that you should suspect FH as a possible diagnosis in adult with total cholesterol level greater than 7.5. Okay, so yeah, that thing is correct. That is also what is in past medicine. So according to Simon Broome criteria, in adult, total cholesterol of more than 7.5, LDL more than 4.9, or children more than 6.7 and greater than 4. So yeah, that's Simon Broome criteria. So what is here is also like part of what is in medicine, but then I think he did his own more details twice. So
because if someone is not careful, you might think that you only refer when TC is more than 9.0. You get.
So here now, what he's saying is that if the TC is this more than 7.5, then the LDL more than 4.9, or non-LDL more than 5.9.
There's nothing like referral here.
Yes, no secondary cause. Suspect.
You just say suspect this.
But don't use curious.
When you now you refer once it's 9.0, which is you don't have to wait till 9.0 before you even refer. I don't know if you get what I'm saying.
I get your point. All the familiar should be referred, isn't it? That's what you're trying to say.
From the beginning.
Okay. So let's read the management from past medicine. So the use of CVD risk estimation using standard table is not appropriate in familial hypercholesterolemia, as they do not accurately reflect the risk of CVD. So referral to a specialist lipid clinic is usually required. High dose statins are usually used first. So when you suspect, I think we can start the statins. Then first degree relative have a 50% chance of having the disorder and should therefore be offered screening. This includes children who should be screened by the age of 10 years if they have one family member affected. So okay. Then statin should be discontinued in women 3 months before conception due to the risk of congenital defect. So I think, who remembers about what they said? If 2 family members have it, I think we should screen the child at 5 years, right? If one family
Yeah,
member has it, we screen them at 10. Two family member, we
yeah.
screen them at 5. Yeah, so we can start. So maybe when you suspect, you start. Then if the lipid, whatever. Okay. So well, it is fine. It's all right. I get your point. I get what you are trying to say. But somebody open nice guideline about familial hypercholesterolemia? Let's be sure of what is the current guideline. So because here it's saying refer to lipid clinic for further assessment if clinical diagnosis of FH or if T. But actually it said if there is a clinical diagnosis, you should still refer. Or if total cholesterol is more than 9 and or LD,
Do you know what clinical diagnosis is?
that is the broom. The clinical diagnosis when you are using the Simon broom now.
No, so clinical diagnosis is not Simon Broom. Simon Broom itself is like they are setting is like a questionnaire that asks so many questions
Uh,
that you do like have you got premature coronary heart disease? Have you got they use so many things together
Is it not the
for
Simon Broom? Is it not this one I read now? Age, total cholesterol, LDL, tendon diatoma, DNA-based evidence of LDL, family history of premature CVD, and family history of extremely
yeah,
high
those are the
cholesterol.
things in the
That's what we
Simon
use
Broom.
there. Then
Okay,
for
yeah.
douche, what is douche? Um, what
It's
is
almost the same thing.
is almost the same thing. Okay. Can somebody
Yeah.
open nice guideline? I beg. Let's make sure that this thing here is correct because since
Is it
Doctor
for the criteria or for what?
No, because you were saying that one will be thinking that what I want to know is when you get this value to suspect familial hypercholesterolemia, what do you do? Do we start treating it in primary care?
Start treatment and you refer.
You start treatment and you refer. Okay.
Yeah. My argument was the value. Do you
Okay.
get
The
the
value.
7.5 and the 9?
Okay, and the
That was
nine.
just what I felt that it
Okay, that
might be
was
a
what
little
was
bit.
okay. All right.
Yeah.
So I think I don't really know, but what they're saying here is that refer to lipid clinic for further assessment, clinical diagnosis of FH, or if TC is more than 9 and or LDC more than 6.5 or non-LDC more than 7.5, fasting triglyceride are more than 10, regardless of family history. So I think this value here
Mm.
comes with family and personal history. Look at it here. So if the TC is more than 7.5 and LDC is more than 4.9, there's a personal or family history of confirmed CHD less than 60 and with no secondary causes, suspect the familial hypercholesterolemia. Do you understand? And then you manage it the same way. But in the case where there is even no family history, once the value is the TC is more than 9 and our LDLC is more than 6.5 and our non-HDL is more than 7.5, then regardless of family history, do you understand, you'd still go ahead and refer the patient. Treatment targeting familial hypercholesterolemia. If clinical diagnosis of familial hypercholesterolemia and other risk factor present, follow the recommended treatment and management pathway for primary or secondary prevention as for non-FH, but aim to achieve at least a 50% reduction of LDL or non-fasting non-HDL from baseline. Consider specialist referral for further treatment and or consideration of PCSK9 therapy. Who understand what these people are saying? Because I don't know. Me, I don't understand.
Let me see. Where did you say? Well, consider special effect for that treatment and or consider of. I've never heard of that before.
Okay.
But I have to check the meaning online.
All right. So
So
treatment
then that's
target.
medicine.
If there is a clinical diagnosis of familial hypercholesterolemia or and the other risk factor present, follow the recommended treatment management pathway for primary or secondary prevention as for non-FH, but aim to achieve at least 50% reduction of LDLC or non-fasting HDLC from baseline. Consider specialist referral for further treatment and or consider PCSK9 therapy if they are assessed to be at very high risk of coronary events or therapy is not tolerated. So specialist referral for further treatments. I don't really heard that PCSK9 before. It assessed to be at very high risk of coronary event or therapy is not tolerated or LDLC remains more than 5 in bracket primary prevention or LDLC remains more than 3.5 secondary prevention despite maximal tolerated statin and ezetimibe therapy defined as any of the following: established coronary heart disease, two or more other coronary heart disease series factor. Okay, so I think another thing that maybe when we are answering more questions in past medicine in this metabolic, these certain things will be clearer again because nah man, these things are big. Oh. And in the last GP program that was done, they talked much about this 13. I was like, I didn't know that issues about this lipid prevention is this bulky. All right, let's go on. We're already in page 5, so we're almost done with it. Secondary prevention offers statin therapy to adults with CVD. This include angina, previous MI, revascularization, stroke or TIA, or symptomatic peripheral artery disease. Is in red because if you don't do it, it's a significant event. So systematic peripheral artery disease, do not delay starting treatment if a person has acute coronary syndrome. Take a lipid sample on admission. So take note there is no heart failure in this, right? Because there was one of my patients that had heart failure. So I was trying to check if heart failure is part of this criteria that you start a secondary prevention. Identify and address all modifiable risk factors like smoking, diet, obesity, alcohol, physical. Why? Okay. So do not what? Do not delay what? Do not delay starting treatment in secondary prevention. Why? Managing modifiable